So I got asked the other day by a girlfriend on voice text, hey, I was charged $225 for a telehealth appointment with a general practitioner. Does that seem like a lot? And from initial onset, it's a hard financial world out there. I would say, yeah, that feels like a lot of money. But as an actual practitioner, I understand the value of what went into that. And so I described my response as this to her. I said, first of all, you got to realize that when you walk in the door, that practitioner, if they're a good one, or if they're one that really cares, one that's done their research and their homework, they've more than likely put at least 15 minutes into prepping for your appointment, whether that's looking over labs, imaging, corresponding with pharmacists, ordering tests ahead of time, reviewing some things in the literature for you, and then trying to get a game plan together basically before they walk in the door. I said, so you gotta realize they're really putting in some homework before they even come to the table with your appointment so that they can have an open listening ear, hopefully, if they're someone that is really having great bedside manners to you, and can then network navigate algorithm in that time frame because they've done the prep, and now we can integrate the story, the history that you give us, and then we can make a plan and decision with a teamwork structure moving forward. So at $225, it's not really just the 15 minutes that you're paying for. It's the 15 minutes beforehand, or even up to 30 minutes, or maybe an hour, depending on what you've got going on. And then it's also the overhead. Obviously, if they're running a business, they have a front desk person. They probably have, maybe if they use insurance, well, probably not insurance because it's a cash pay patient, excuse me. But, there's operating costs, the phones, the internet, the lab company, guess what? They kind of cost to come to your door, things like that. So $225, yeah, it seems like a lot. But as a practitioner who is also in an entrepreneurial way running her own business, I can understand the price point. Now, that being said, why is functional medicine or direct primary care or specialists kind of around town, which is really kind of the vogue of where pendulum has swung in terms of medicine in this day and age? There's kind of a rebranding of not going to large institutions anymore, but looking for small mom and pop shops. Why are we using cash? What's behind that? Why can't I use my insurance? Well, largely because there's a few things, but when it comes to the insurance-based model, insurance really plays a large role in governing what tools and therapies and algorithms we have to treat the people in front of us with. So for example, a hypothyroid patient, most insurances will say you have to use levothyroxine or Synthroid, this synthetic T4, and prove that the patient doesn't do well on it before we will consider covering something like AmeriCorps, which is a combination of T3 and T4 drug, or NP thyroid, similar cousin to the AmeriCorps. And that's kind of tricky because if I'm a practitioner and I just, from knowing Susie Q in front of me, thinks that she's going to need something that's going to need a T3 combination product versus just a T4 alone, and I want to choose Armor NP first, right out the bat as my primary treating drug, well, I can't because the insurance won't cover it right off the bat. And that's just not fair to the clinician and to the patient in front of me, right? So insurance can get tricky when it becomes an outpatient form of choosing the right therapy for what you want to have happen as a bodily response with favorable outcomes. That's the first thing as to why people are moving into cash pay models. It's to unhook from the insurance kind of governance, the best way to say that, so that we have more options available to us. Also, insurance will not cover certain testing, like a Dutch test that's a urine-based metabolite hormone kit that comes to your door so we can look at the breakdown of how your estradiol, testosterone, progesterone behaves, etc. Insurance also will not cover some off-brand pharmaceuticals that have been repurposed, things like intranasal oxytocin or ivermectin, hot word on the block. And then insurance also won't cover, some things like peptide therapies that are just not patented, or bioidentical hormone therapy. Again, not patented because bioidentical, exactly as it sounds, is bioidentical, molecularly the same as what you produce as your own chemistry for estrogen, progesterone, and testosterone versus a synthetic product, which insurance will cover because it came from pregnant horse urine and therefore it's patentable and it can make a profit. So practitioners who are in this outpatient model who are really trying to introduce to the public wellness, integrative, holistic health, healing, and keep you well. And so you don't have to ever go to the doctor in the first place. A lot of their tools, tips, techniques, and programs are going to involve more things that are unhooked from the insurance directives and guidance, and that are not a pill for every ill born from a prescription pad standpoint. And so we really need to capture revenue in a way that keeps us alive because insurance is not backing us with financial support, if that makes sense. So we'll stop there because that's the first kind of introduction into, well, why does that $225 cost me so much? One, because we don't have insurance pay towards us, but we're purposely doing that so that we can get you the tools that you need that really govern wellness instead of make you chronically demanding chronically dependent on pharmaceutical products. And two, because we value the time that we put into all of the pre-work and labor before the scenes and after the scenes, to be frank, that will go into just that 15-minute appointment that you experience on the front end is 15 minutes, but then on the back end to us really will more than likely manifest at least 30 minutes, if not 45, an hour plus.